Welcome to another episode of the Align and Elevated podcast. I'm your host, Dr. Allison Feld, owner of Body Motion Physical Therapy, pelvic expert physical therapist, and I'm here with my doggy today, Bucky. He is joining us if you are watching on YouTube. He came to the office to get some EMTT. It's a magnetic high frequency pulse. If you've heard of PIMF or like a PIMF mat, it is similar to that, except for this is a high frequency magnet, and it's similar to that of an MRI, but used in therapeutic doses to help decrease inflammation, help stimulate bone healing, help stimulate healing in general. And it's been absolutely amazing. So I had Bucky come into the clinic so I could do it on his back and his hips because he is having days where he is struggling walking and all that stuff. But this episode is not about EMTT. This episode is all about considerations for managing and healing pelvic organ prolapse. So if you've heard of pelvic organ prolapse, there are multiple kinds of pelvic organ prolapse. I want to take you through my own journey with pelvic organ prolapse and a little bit about other patients that I've treated, about how they heal and how they've managed their symptoms through the years. And then I want to give you some insights into what I've seen with surgical management as well from a clinical perspective. Now, I think these are all important considerations because I wanted to empower you. When you find out that you have a pelvic organ prolapse, it can be really defeating. It can make you feel like crap. It can make you feel like your world is ending, that you can never lift a weight again, you can never do the activities you love, and it's pretty awful. People will describe it as feeling like their vagina is coming out of their body, their rectum's coming out of their body, or they just feel like things are dropping and they feel a ton of pressure. So the definition of pelvic organ prolapse is typically when there's multiple kinds of pelvic organ prolapse. I guess I'll go through that first. First, you can imagine that you have your vaginal canal leads to the vaginal opening. When you have your vaginal canal, you have the front side of it and you have the back side of it, and then you have the top. And on the very top, you have the cervix. And when the cervix comes down, that means that the uterus is descending, and that is called a uterine prolapse. So the uterine prolapse is when the cervix is coming down into the vaginal canal and sometimes comes outside of the body. Then we have a rectocele, which is where the posterior wall, the back wall of the rectum, of the vaginal canal, the back wall of the vaginal canal comes into the vaginal canal. Then we have a cystocele, where the front wall of the vaginal canal comes into the vaginal canal. And that is where the bladder is coming in. And it can also be where the urethra will start to come in as well. So you can have a urethrocoele, which is where the bladder and the urethra descend into the vaginal canal, or you can have it where just the urethra starts to come down a little bit. And now all of this can lead to urinary incontinence, it can lead to a lot of urgency, it can lead to constipation or bloating, it can lead to back pain or pelvic pain, all because of this pelvic organ prolapse. So I want to take you through my journey of pelvic organ prolapse so you just have an idea of like how common this is. So some of the research will say 2 out of 3 women after they have childbirth will have pelvic organ prolapse. We honestly see a higher rate of that. We believe, it's really like everyone has some descent of their pelvic organs after they have a baby, whether they feel it or not. And the whole goal is to heal the body and heal the core so that the organs can go back to their homes and find the places where they live. And then you can do all the activities that you love without feeling heaviness, without feeling like something's falling out, without feeling uncomfortable in your vagina or between your legs. I'm going to go back, and I'm sorry this is a little out of sync, but there's also, you can also have a rectal prolapse. So that is where the rectum starts to come out of the anus, and that's a little more uncommon, at least for women. And then you can also have a perineocele, which is where the area between the vagina and the anus start to descend. Okay, so it might feel like there's just this bulge between your anus and your vagina, and that tends to be what's called a perineocele. And so it just means that the central tendon that holds that area up has ruptured or become lengthened, and now you're not getting that area held up anymore by that tendon, by that central tendon. And so you're just relying on the muscles themselves. So that's a perineocele. Again, a lot less common. Okay, let's backtrack it to what do we do? a lot of people are so freaked out when they find out that they have some descent of their pelvic organs. I've had so many people tell me if they would have known that this could have happened, they would have never had kids in the first place. And that is super disheartening because we just haven't educated people to feel powerful even if they have a pelvic organ prolapse. Like, this should not form your identity. It's just a part of me. I have a pelvic organ prolapse, and it has zero effect on how I identify my life, how I set my fitness goals. It has zero effect on my self-worth. And I want that for everybody because if you go down the online rabbit hole, even like support groups for pelvic organ prolapse, they're super negative. They're bad, like they're not helpful, a lot of them. You know, they might be like, oh, go try this program, these exercises, those exercises. But at the end of the day, like, it's not necessarily empowering, and you have a lot of fear-based knowledge and kind of like fear-based mindset that are preventing these women from going and pursuing what they want to do, and they're basing their limitations on their diagnosis of a pelvic organ prolapse, and that is just not okay. We want to be empowering. If you have a pelvic organ prolapse, you should be able to do everything that your kid can do, okay? Or everything that your friend without a pelvic organ prolapse can do. That's the reality that we need to make true for you, and how we get there might look a little different, but I'll tell you my story. I'll tell you how I've gotten there. I'm a pelvic floor physical therapist. I have been that since before I even had children. And so when I graduated PT school and I was getting my own pelvic floor training and exams, one of the instructors came over and they're like, okay, this is a cystocele. You have a grade 2 cystocele. And it's actually pretty significant. It was below my hymen remnants, which just means that it's a grade 2 that descends a little bit lower. And I was like, oh, I wonder if this is why I've had incontinence since I was a kid. And, you know, it made me question a lot of things. But all I could think about, and I used to pee my pants in 2 things. When I would get hit in hockey, I played boys hockey, and anytime I would take a body check, I would pee my pants a little bit. And then I would also pee my pants when I would do sprints during softball in high school. And so those were kind of clues that something wasn't right, but, you know, I was too embarrassed to talk about it. And so until I became a pelvic floor PT, I didn't even realize that, like, oh, this is kind of common and there's actually help for this. So those are my 2 real instances. I started weightlifting when I was 14, like doing some more heavy weightlifting, 14, 15. And I was training for hockey. I was like at a really intense hockey training facility in Brainerd, Minnesota, and I would train there. I trained at Minnesota hockey camps. And that's really where I got into lifting, performance-based lifting for hockey. And I would lift 4 or 5 days a week, probably 5 days a week actually, and I would lift heavy. And when I would train, I would, I trained with all these men. There really weren't females there. And at this point in time, you know, we're talking in 2000, right? 1999, 2000. And there just wasn't a ton of research and stuff for performance-based female athletes for weightlifting. And so we didn't really have education that, like, oh, maybe how you're lifting weights as a female and how you're lifting weights as a man, maybe you guys should be breathing differently, or maybe you should have different considerations. The men have their penises and balls hanging out of their body. They don't have to keep those inside their body. Whereas women have to keep their bladder inside their body, their uterus inside their body, right? And so there are different considerations when it comes to how we should brace and use our intra-abdominal pressure as females. And now, I know that this can be controversial and there's like a lot of different information about that, and everyone is different and everyone's goals are different. But for me, I would PR, I would try to hit max repetition or max weight for my like 1 repetition max. But really I was performance training for hockey to be, excellent and strong on the ice. And so I didn't necessarily need to max out all the time, but I had to be able to have good breath patterns. And that just wasn't on my radar. That wasn't a thing. So I probably created a little bit of my own pelvic organ prolapse by using poor breath patterns and lifting heavy, heavy weights without the information of knowing how to control my intra-abdominal pressure as a teenager. And then I would took heavy hits as a teenager, and that's probably didn't help my situation. So, I can't pinpoint exactly when I got a pelvic organ prolapse as a kid, but it happened. The other reality is that my pelvic floor was really tight. So I had a completely tight pelvic floor, and I didn't know how to control my pelvic floor, but I had a lot of tension. And so as a female athlete, a lot of female athletes have a lot of tension in their hips and in their pelvic floor, and they don't find that their hips are flexible, and they just have a hard time getting deep stretches in their hips, or they just have no connection. No one ever really trains us to connect to our pelvic floor. So in turn, I developed a really tight probably fibrotic pelvic floor. And when you have a tight fibrotic pelvic floor, you end up having less dynamic movement from your core. So the pelvic floor is at the bottom of your core. And in order for your pelvic floor to be strong, you actually have to have really good opening and really good closure. You have to be able to overstretch as well. And so when you have that full range of motion, that means that you're going to have more shock absorption. That means you're going to have a really strong dynamic core that can absorb forces when you're taking a hit in hockey. But you see, my pelvic floor was tightened. My pelvic floor was shortened. And when you have a shortened, tightened pelvic floor, that puts a lot more pressure in your abdominal region, increasing the pressure down on the bladder, down on the uterus, down on the posterior wall of the vagina, which would be your rectum. And so the posterior wall, which is where the rectum is, I should say, that's more anatomically correct. But regardless, that's neither here nor there. The deal is that when the pelvic floor is tighter, there is just more intra-abdominal pressure. And I had a ton of bloating and constipation as a kid, as like a teenager, and especially through college. Like, you gave me a bagel and cream cheese before I played, I could guarantee you that I would have like intestinal discomfort on the ice. And I would, sometimes have a couple bagels and cream cheese, and I loaded up that cream cheese because I was quote unquote carb loading for the game, right? And so that wasn't good. So was it diet, or was it that my pelvic floor was super tight and I already had a high intra-abdominal pressure? So if you imagine, like, I have a balloon here and I squeeze the bottom of the balloon, that's the tightness of the pelvic floor. That puts a lot more pressure up in the abdomen. When you're putting a lot more pressure up in the abdomen, that's going to put a lot of downward pressure down on the pelvic organs. And if your pelvic floor is already tight, there's not going to be a lot of room to hold those organs up and in. So one of the analogies I really love is if you imagine that your pelvic floor is a bowl, and that bowl is nice and open, and you have a grape in that bowl, the grape can just like roll around and move in the bowl, and imagine that grape is your bladder. That's what should be happening. But if your bowl is super, super tight, it's going to squeeze that grape. It's going to push that grape down further, creating a descent of the bladder, creating that pelvic organ prolapse. And so in order to help take the pressure off that bladder, we have to work on opening up the pelvic floor and allowing the pelvic floor to open and have space. And allowing that pelvic floor to open and have space. And so once we get that space, then we can really have a dynamic pelvic floor and to have less pressure on the pelvic organs themselves. And so as a teenager, having a super tight pelvic floor, you can imagine that I had high intra-abdominal pressure. Fast forward, I go and play college hockey, and I continue to be an athlete even after I do hockey. I run some marathons when I'm done with hockey because I don't know what else to do, and I was super bulky and I wanted to lose some of my muscle mass, and so I started running marathons and tried to run the fat, the muscle off of my body and just kind of de-bulk. Do I wish I did that now? Probably not, because now my goal is 100% all muscle, but that's a story for another day. But so fast forward to then I go and I am pregnant with my first baby, and I know I have a cystocele. And I'm already a pelvic floor physical therapist. So I'm doing everything I know how to do in order to open up my pelvic floor, in order to work on breathing and coordinating my pelvic floor. But the reality is that my pelvic floor was still really tight. So if you've read my book, Pregnancy Era, you know that I ended up pushing for over 3 hours. I blew every blood vessel in my eyes, in my face. I looked like I had a tan even though I didn't. And I And it was pretty rough. It was not just pretty rough, it was very rough, right? I pushed for hours, breath holding, which is everything that we teach everyone not to do now. And all of that was generated from my own experience, because when I was pushing for that long and breath holding and using the intra-abdominal pressure to help descend the baby out of my body, I was not just pushing the baby out. I was pushing my uterus down, I was pushing my bladder down, and I was pushing for hours and hours to do that, to get them out of my body. Then I go and have a pretty significant grade 2 tear. And so then once you have a grade 2 tear, or you have any tearing at all, you get scar tissue that buckles down, right? And scar tissue is there to heal the body and to create tension so you don't open up that tissue again. But what it also does is it creates a ton of tightness, again, making the bowl even tighter, and therefore exacerbating the amount of pressure that there is on those pelvic organs. Okay, so then fast forward, after by this time I had my second, even though the delivery was a little bit better, and I still had such a tight pelvic floor that my bladder was significantly worse after baby number 2. Didn't, symptom wise, it recoiled pretty well after baby number 1. I didn't really do a lot of internal manual therapy. I did what I know how to do myself, but I couldn't do a lot of my own internal work, and I didn't have access to it at that time. There wasn't a lot of people in my area. I was working a ton, so just didn't get the work that I needed in order to heal my body. And so fast forward, I decide I'm going to run another half marathon in order to get myself back, get my fitness back, and start running. And I start training, start running, and my bladder's just in a bad spot. And so I go and I get a pessary. And I get a pessary to really support the bladder, support my training. And then what I also did was start to get my own internal work done and start training other physical therapists as they joined the Body Motion team, because I knew I needed this manual work. So maybe expanding the business was all for personal gain and not the mission. I don't know, but I am part of the mission. So because I'm a woman and we strive to empower, to heal women, make them strong in their bodies, give them all the fulfillment in the world, which unlocks their creativity so they can go make really good impacts on the world. That's the deal. And so regardless, started hiring people, started training them, and getting my own internal work done. And once I got my own scar tissue work done, and then really started opening up all the chronic years of tightness and tension in my pelvic floor, improving my range of motion, that's when my prolapse symptoms completely dissolved and went away. Now, would my bladder still descend some? Yes, absolutely. But it's a non-issue because I don't feel it and I don't become symptomatic. The only time I run into issues now is if I have a sickness. Like if I get a chronic cough or chronic vomiting or some vomiting or stomach bug, I will get a little bit of incontinence. If I train really, really hard and my legs are sore, or I play like more than probably 3 hockey games in about a 48-hour window, then I will get a little bit of leakage. But those are my only symptoms. And it's amazing. Like I just don't even realize I have a prolapse now, because my prolapse has recoiled, but even when I get checked, like it still comes down to a grade 2 below the hymen remnants. Like that, the position of that has not changed, but the symptoms are completely gone, and it's not getting worse as I get older. And then I had a third baby, and it was a non-issue, did not get worse at all, was actually even better because I had pelvic floor work done my entire pregnancy. So we managed the tension, the tightness of my bowl, the whole entire pregnancy, really working on giving me range of motion. And when I had that range of motion, then my bladder could just go back up to where it needed to go. And even with a baby growing on my bladder, my bladder didn't descend. So that just shows you the power of pelvic floor work. And so I had a bunch of pelvic floor work done. And then healing postpartum, I just really didn't feel my bladder this go around, which was such a gift. And, occasionally, like I said, I will get some symptoms, but I really manage that. I use EMTT, which is amazing to help improve bladder control, amazing to change pain. It's amazing. Blah, 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 blah. I also use shockwave therapy to help with my abdominal core tightening, and we use a technique to help strengthen one of the ligaments that goes from your belly button to your bladder, and then that's called the urachus ligament, and that has helped tremendously improve the position of my bladder. So I feel like I have all the tools. I also use pelvic floor physical therapy, typically about once a month for just maintenance reasons, to keep my pelvic floor as dynamic and open as possible. I also train really hard. So I lift 4 to 5 days a week. I do 2 heavy leg days a week, 2 upper body and back days, and then the 5th day is just a glute trigger day, just to turn my glutes on. And these are essential at helping me keep my pelvic organs in place, keep my pelvic floor healthy. When you have really strong glutes and a strong back and a strong transverse abdominis muscle, you have a really good core. Now, if you have, and you need that pelvic floor to stay dynamic, the minute that pelvic floor starts to tighten and overwork, it's going to take over. It's going to limit your hip extension, which is going to then limit how much your glutes can help you. So your glute medius muscle especially, and your glute minimus, they help support your pelvis, and they sling the pelvic organs along with your lat muscles and your lower trap muscles. They create this sling of fascia that's going to help support the pelvic organs. And you combine that with knowing how to use your breath and knowing how to breathe during your lifts, consciously breathe and use your breath to manage your pressure, your intra-abdominal pressure. That's going to help you manage the pressure that's down on your pelvic organs. Also, it's going to help you manage your pelvic floor tension. So the other thing that is a misnomer, and one of the nitty gritty things that we focus on when we're working with someone to help their organs recoil, is we really work on getting their transverse abdominis, their lower transverse abdominis, to fire adequately. And for your transverse abdominis to drive a lot of your movement, to drive your lifting, to drive how you pick when you pick up your kids, to drive when you bend over to pick up a laundry basket. If that muscle can drive your movement and it fires first over the pelvic floor, then you're going to have a better chance at that transverse abdominis picking up your pelvic organs and the bladder just coming along for the ride. But if your pelvic floor is tightening and you're doing a Kegel before you do this movement, most of the time you're still going to have all that pressure pushing those organs down, and a lot of times you're going to contract your pelvic floor, but your organs are going to be below the line of your pelvic floor. So you're actually creating more pressure and worsening of the position of those pelvic organs because of the starting position of the organs. So it's really important that if you can work with a pelvic floor physical therapist, or at least start to get to know your own body and really figure out, okay, how can I learn how to open up my pelvic floor? How can I get more range of motion on my pelvic floor? Can I massage my own pelvic floor? Can I use a pelvic floor wand to help me get more range of motion? I'll tell you what, if I didn't have the resources that I do in my own team of pelvic floor physical therapists that are complete experts and have all the resources in the world to heal the worst of worst prolapses, then I absolutely believe that if I didn't have that, I would be working my wand a lot, and I would be using a wand to help open up the pelvic floor and get me that range of motion so that my pelvic floor could be dynamic, could open really wide, and then can recoil nicely. You don't really need to train the Kegel. You don't need to train that pelvic floor contraction. The reason being is most people are so contracted to begin with. And when you can train the opening and you have that opening, every squat you do, every walk you go on, you're going to get some ground reaction force of that pelvic floor muscle. So functionally, it's working. Do you need to stick weights up inside your vagina? No. You don't use weights on your diaphragm that you breathe with, right? You inhale and exhale. You can put the air in different parts of your belly and in your rib cage and in your back and in your pelvic floor. Yeah, that's great. And then exhale. But you don't weight that. You don't put weights on that. You can, breathe into restrictive things to make it, more forceful and make your lungs stronger and make your diaphragm stronger, sure. But you just don't need to put weights on your pelvic floor. If you're not putting weights on your diaphragm, you don't need to put weights on your pelvic floor. There's just not a lot of times that that's called for. It's extremely rare. Now, if you have a nerve injury and we're trying to get the nerve to fire back to the muscle, or you have a complete muscle tear of your levator ani, which is one of your pelvic floor muscles, then sure, go ahead and, we can start to retrain it. And if that requires retraining it and you get better connection when you stick a weight in there, sure. But that's the minority. If you have a pelvic organ prolapse, most likely your bowl is already tight because it's compensatory. Your body subconsciously is like, let me keep these organs inside my body, right? And so you're gonna have this like low grade tension of tightening your pelvic floor. You're gonna have a low grade tension of trying to keep everything in. And so you intentionally need to work on opening that pelvic floor, which is going to give you that range of motion, which is going to give you that space for your organs, which is going to help decrease the pressure, decrease the incontinence, and make that pelvic organ prolapse, give it a chance to heal, give it a chance to recoil, to go up into its spot again. And so back to my own personal story. So after number 2, I used a pessary probably for about 18 months. And then I really just felt like I didn't need it anymore. I didn't think that it was supporting me. I didn't feel any pelvic pressure. So I felt really good to go after that. I would also use KT tape to lift my bladder when I would go on runs or when I would do HIIT workouts that included plyometrics. So I would lift my bladder up and then I would stick the KT tape underneath it, just giving it a little bit of support on my abdominal wall. Now, it helped me mentally. I also became certified in hypopressives, and the reason I decided to do that was to help control my prolapse and just give me a lot more core strengthening and core tightening without driving the movement with Kegels. So hypopressives and low pressure fitness are amazing because they help you learn how to vacuum and create a negative intra-abdominal pressure, which creates actually the only exercise that has ever created negative pressures in the vaginal canal and in the rectal canal is using low pressure fitness and hypopressives. And so it's a form of exercise in which you create this abdominal vacuum, and it's a passive vacuum. So if you follow bodybuilders or you look at a lot of Instagrams, people are actively contracting their core when they do vacuums. So that is not a hypopressive. That is not low pressure fitness. Low pressure fitness and hypopressives are passive. You're not actively engaging the TA or the obliques or the rectus abdominis. This is all passive, and you're using your breath and your diaphragm to control and create a negative pressure, which helps sucks and pull the organs back up into their places. Maybe we can link a video if you're watching on YouTube or if you are listening on Spotify or wherever you get your podcast. We'll link a video to this episode, and we will show you a hypopressive and how to do a hypopressive, because I do think it's super great. It's good for the pelvic floor. It's good for learning diaphragm control. It's good for learning intra-abdominal pressure control. So we'll link that here. So I used that on my journey. And I was certified through level 3, which is the max level for low pressure fitness. And I don't really use any of those poses per se, but just the concepts are really, really valuable. And I'll often do it a lot of times after I'm done lifting, just to kind of reposition my organs and make sure I take the pressure off my pelvic floor for just a little bit. And then I will follow it with doing some breathing, doing some opening, making sure I have that dynamic opening, because you do get an elevation of the pelvic floor when you do a hypopressive. So I use that as my training. And then I really started after baby number 3 came along, and I was like, okay, I never ever want to get a pelvic organ prolapse surgery. The reason being is I've seen them and they fail. There is such a high failure rate, and I think a lot of it is because people don't actually learn how to use their pelvic floor, and then their bowls are super tight, so then they are still creating all this intra-abdominal pressure, and they just bust through the sling, or they bust through whatever they use to stitch up and make things tighter and reposition their organs. So it's not ideal. The ideal way to do this, even if you end up having to get a pelvic organ prolapse surgery, and I'm not going to say I'm not going to ever get one. It could be on the table for me. I've had a prolapse for a long ass time, and if it ever does get to a point that I can't manage it with pelvic floor physical therapy, keeping my muscles strong, and whatnot, then I will absolutely consider that, because I don't want it to affect my function, but I will exhaust every single natural resource before I go that route, because I've seen these things fail like so much. And then even once I see them fixed post-op, a lot of times anatomically when you visualize it, that freaking prolapse is still there. They've maybe just tightened a ligament and like pulled it up a little bit, but you still see the descent. And so it's not like they're fixing it. So when people freak out that like, oh, my bladder's lower, or, you know, whatever, and they think that the surgery is gonna totally reposition it, I hate to break it to you, but it's not. So if you're freaking out because your prolapse looks low, or like it just visually your vulva doesn't look good, getting the prolapse surgery is actually not the answer. Because I've seen it where I'm like, wait, they fixed your bladder? I'm like, why the fuck is your bladder in the same spot? Like, I don't know. I don't have the answer, but they fixed it. Like, I don't know. It's wild, but that is the deal. Like, and surgeons stand by their work, right? They're like, yeah, we did the post-op. This person now, you know, they had the cystocele. We did the surgery. And I'm like, there's still a cystocele. What did you do the surgery on? But whatever. Like, okay, it's a little tighter. But anyways, so like, that's where I just want to like make it super clear that like surgery is like not the answer. And unless, like, the only time I've really seen like these surgeries be effective, at least for a little while, is when people have a uterine prolapse and then they get they either get a hysterectomy and then they have like this volt. But then a lot of times I will see what happens is that volt then prolapses, and because it doesn't have that ligamentous structure to hold it up. So I don't feel like there's a good surgical answer at the moment. I should get a surgeon on here so they could talk us through some better options. And so maybe that will be my next move, is to find a surgeon that will come on the podcast and kind of talk to us about this. So I don't want to speak for like good surgical outcomes, because I'm sure there are some, but I do really want to bring attention to like getting everything you can control. You can control getting internal pelvic floor work done, really opening up the pelvic floor, improving the health of that pelvic floor, creating a dynamic pelvic floor to give the organs a chance to breathe and go back into their places and not be so strangulated that they get strangled out of the body, squeezed out of the body. So you can control that. You can control getting your scar tissue released to help release some of that strangulation and some of that squeeze on those pelvic organs. You can control your bowel movements. So having good bowel movements is super important to me. I use magnesium citrate every single night. I keep a high fiber diet. If I've noticed that my fiber intake is low, I will take some fiber, or I'll use raw husk psyllium in order to help beef up my stool and just get it a little bit more consistent if I'm struggling with that at any particular time. I also am a big believer in having adequate protein intake. So I used to say collagen, and sure, collagen can play a role in it. I definitely was on the collagen train between baby number 2 and baby number 3. And about my first year postpartum of baby number 3, I was definitely on the collagen train. But then I really switched to like, collagen's not a complete protein. And if you have adequate protein and like you're actually eating your body weight in protein in grams, then of your lean muscle mass, and you've heard me talk about that on other episodes, then you're going to have the protein available for your muscles to turn over and for your collagen production to increase and improve, which is going to help with the health of all the tissues, which is going to help with your ability of your pelvic organs to recoil and go back to their places. And so I think that's a really important keynote, is if you are struggling with pelvic organ prolapse, then you absolutely need to consider making sure you have adequate protein intake and adequate fiber intake. You don't want to increase constipation by having protein, but the reality is if you're eating a balanced diet and you're not restricting carbohydrates and you're eating adequate protein, you should have really good bowel movements that are well formed, soft and easy to pass, and you shouldn't have to strain. If you're having to strain and you can't breathe your poop out, then that is going to put more pressure on the pelvic organs themselves, which can worsen your pelvic organ prolapse, or at least worsen your symptoms of pelvic organ prolapse. And so it is important for you to learn how to manage your bowels, even if you have a cystocele. If you have a cystocele, then one of the main things to do when you have a cystocele or you have a bladder prolapse is to really make sure that you are getting really good bowel movements and you have really good digestion. Because if you have a lot of stool collecting and you're getting constipation on your bladder, like that's going to be really heavy for your bladder, and that is going to put more downward force on the bladder. So getting in a good, consistent bowel routine where you have a good bowel movement every single day, that's going to be really important for managing your pelvic organ prolapse. And so that was my story. That's what I've done. If for some reason, like bowels are really, really tough, I will high dose vitamin C to increase my motility. Now, do not do that if you are pregnant, because that stimulation of peristalsis from vitamin C can increase uterine contractions, and we don't want to do that. So definitely, work with your provider on that. But that's just what I do personally in order to help manage my prolapses, or manage my prolapse. I do secretly think that my uterus is, has fallen a little bit too, because my cervix does descend quite low during menstruation, but that's very common. A lot of people are going to be heavier during menstruation because you have a lot of lining to slough. So it's really common that you get descent. Your cervix is going to be at different places during the phase of the menstrual cycle, typically a little lower during ovulation and a lot lower during menstruation, and that is normal. It's only an issue if that is symptomatically bothering you. So whether you have a lot of pelvic pressure when that happens, or you get a lot of pain, or you feel like you can't wear a tampon because your tampon is hitting something or getting crushed, whatever that is. So I hope that normalizes that for you and doesn't freak you out. Also really great to get pelvic floor work done during your menstruation and during your ovulation, because then you can figure out can I keep my pelvic floor relaxed? Can things stay open during those phases? So we always encourage people when they're on their course of plan of care to actually get the work done at all the phases of their cycle, so we can see where their cervix is, and then can their pelvic floor stay dynamic and open during all the phases of the menstrual cycle, and then can they train during all the phases of their menstrual cycle? So can they get their glutes strong? Can they do their exercises they want to do? That's all really important in keeping the pelvic floor and keeping the pelvic organ in their places, keeping the pelvic organs in their places. So bowel movements become an important conversation. And then, we talked about lifting, we talked about exercise, and we talked about core control, and we talked about intra-abdominal pressure. These are all important conversations and considerations when talking about healing the prolapse, so making sure that the prolapse can start to heal and go back to its home, and then also decreasing the symptoms. So are some people always going to have the position of the prolapse? Yes. But like I said, even if you get the surgery, you might still have that position. Not everybody, but a lot of people. And so the symptoms don't usually always correlate with where the position of your pelvic organ prolapse is. And so that's just something to keep in mind. So if you are constantly chronically checking your pelvic floor and you're like, oh my God, my bladder's lower today, or oh my God, I see my cervix today, or shoot, that rectocele is lower today than it was yesterday. You just have to realize your body's going to be changing and it's going to be dynamic. Other considerations are you breastfeeding? Things are going to, hormonally, estrogen and progesterone are still going to be inhibited when you're breastfeeding. That prolactin needs to be expressed. And so things, the quality and health of the tissue, the firmness of the tissue isn't going to come back to full fruition until that breastfeeding is terminated. And then that takes time too. That takes months and months and months after that termination of breastfeeding. Now, is that a reason to stop breastfeeding? Absolutely no. You can control those symptoms regardless of your hormone status. And so I think that's a really important consideration. And I hope you have found a little bit of comfort in this episode, just knowing that this girl plays hockey still, and she has a cystocele, a grade 2 below the hymen remnants, yeah, and maybe a little bit of uterine prolapse, and it does not affect my identity, it doesn't affect my self-worth, and it doesn't affect my sex life either. The other thing I should talk about, the other symptom that I do actually experience some that I have to be cautious of, is vaginal noise. So you can get queefing when you have a pelvic organ prolapse. And so particularly people will explain that they get queefing during intercourse or after intercourse, or they get it after or during yoga class. And so that can be helped and controlled by using hypopressives and also by using your breath, because you can kind of suck up the organs so that air doesn't get trapped if you know how to do a hypopressive. So if you are having some of that and you're struggling with some vaginal noise or with queefing, then I highly recommend training yourself with diaphragmatic breathing and intercostal breathing, and then also using hypopressives. And these are just a combination of exercises that hopefully, maybe I'll go do a separate video on that. They're a combination of exercises that are going to help you gain control and position better of your pelvic organs without getting air trapped inside. It's going to be a little different for everyone. Working with a pelvic expert physical therapist is probably the best way to determine this, but those are just some considerations. So I hope you found this episode helpful. I'm sure there's a million things that I missed and didn't say that I'm going to go to sleep tonight and be like, I should have said this, or I should have mentioned this. But for the meantime, for right now, I'm going to leave it at that.